therapy, bemidronate or hyaluronic acid or excigiva. What is the duration in adjuvant and what's the duration metastatic? And thank you.
So the first question was adjuvant therapy, right? So currently, in the adjuvant therapy, you're talking about not to prevent the bone loss. You're talking about adjuvant therapy for instance, breast cancer, right? So denosumab is not approved for this, right? In terms of the data which are available currently, you could consider to add zoledronic acid 4 milligram every 6 months for patients who are put on, for instance, an aromatase inhibitor. In terms of the duration of the bone-targeted therapy in metastatic disease, this was the second question, I guess, indefinite. So the recommendation, when you review the most recent ESMO guidelines in terms of bone-targeted therapy for breast and for prostate, for instance, but with the breast conference, as soon as the first bone metastasis is detected, an initiation of bone-targeted therapy is recommended. It's not specifically recommended which drug you select, but it's recommended to start. And the duration is indefinite, even when the bone metastases are progressing. Because as has been shown, when you remember the multiple event analysis, as soon as the first SRE is happening, the subsequent SREs are delayed as well. So I would not stop with bone-targeted treatment, even if the disease is progressing in the bone.
Okay, so I have a question, and thank you very much first for your presentation. And I would know from you how to evaluate the response in bone metastasis. Because, we usually depend on bone scan, but we are telling our students that bone scan is something that changed, and then we go for CT, and then we go for plain X-ray, and then you recommend the PET?
You're completely right. This is an excellent point you raised. I think the first thing, we have to somehow define the treatment goal. The main sense of the bone-targeted treatment is to delay or avoid the skeletal-related event, right? And this can be assessed by conventional radiographs. However, as soon as you argue that you want to shrink the bone metastasis, then of course the bone scan is useless, the X-ray or the radiographs are useless as well. The most sensitive methodology in assessing the dimension or the burden of the disease in the bone is, of course, the MRI. And this is regardless of the bone.
What about PET-CT in these situations?
Sorry?
What about PET-CT?
PET-CT,
and PET-MRI in this situation?
Okay. PET-CT has been shown to predict the response, especially in giant cell tumor of the bone. That the PET-CT, or let's say the metabolic response, is somehow preceding the response which can be assessed in the MRI. In terms of the sensitivity, it's more or less the same as the MRI, what I know. However, the PET-CT, I think, is triple the price of the MRI. I think the MRI is around €300. The PET-CT is around €1,000, at least in Europe. This is the price in Europe.
It's not that expensive, actually. But there is a difference, of course, in price. But there is some data from several studies addressing that PET-CT proved to be more accurate in delineating bone metastasis than bone scan or the conventional methods, if available. Actually, in Egypt, it's available in several centers nowadays, and even sponsored.
I mean, and as well, you have to consider, do you want to assess the response in the bone, or do you want to rather assess the occurrence of an SRE? And I think this is the big difference.
The question is to assess response. Of course, assessing SRE can be done by not at all by PET-CT, but assessing response to bone metastasis.
My personal approach when I want to assess the response in the bone, I do the MRI.
Okay.
Because I tell you why. Because when I want to assess the response, I want to do this frequently in a regular interval, and I cannot do a PET-CT every 4 months.
No.
Yeah, of course, but but PET-CT information about the whole skeleton.
Yeah.
That's it. I can compare.
But for assessing the response. So for me, the MRI is more accurate because then I can apply the MRI, for instance, every 4 months.
But MRI for the whole body or
for
the lesion only?
For the lesion.
But for the discovery of a new lesions, I think this it's a little bit controversial, but of course it works to work with every method of detection.
But in the 3 main study of denosumab, you refer that they depend on a questionnaire given to the patient for symptoms. So my question now, it's only for relieving pain and quality of life, or still in these 3 main clinical trials they apply MRI and see the response? Because this may be a little bit guideline for us in practice. Shall we wait until we see a shrinkage in metastasis, or we are that satisfied when the patient is out of any analgesic and this is good response?
Yeah. I would personally focus on delaying the SRE, meaning focus on the symptoms first, right? When we're talking about bone disease. I'm just talking about bone metastasis.
Not liver, no lung, just bone.
And when you're talking about pain, in the integrated analysis, around 50% of the patient had no or mild pain, and the other half, roughly, moderate or severe pain.
Any other questions?
Dr. Amani, you have to ask one question because this is your era. Dr. Mohsen? Okay. Dr. Osman, please. Can anybody help us with microphone? Hi, Stephen.
We know that osteonecrosis is a common complication with the uric acid occurs to lesser extent with denosumab. Did you have explanation for this? Why denosumab is associated with the lower incidence of osteonecrosis of the jaw compared with the uric acid?
There was no difference, but in the denosumab arm, it was numerically higher, the ONJ. It was not lower, it was higher. There was no difference, but it was numerically higher. No, I do not have an explanation, but in terms of the resolve rate of the osteonecrosis of the jaw in both arms, around 85% of the ONJs have been resolved. And in terms of the ONJ, I think the most important thing from the beginning is, are we really talking about ONJ? Because everybody of us had at a certain time point a burning sensation in the chain or in the mouth. And I think the misclassification rate in the daily, let's say, routine practice is very high. First, it has to be shown and confirmed that we are really talking about osteonecrosis of the jaw, right? I personally have seen 1 or 2, because usually when I start with a bone-targeted therapy, I instruct the patient to apply sufficient and appropriate oral hygiene, to apply mouth rinsing, and with this prophylactic measure, I don't think that you will see an osteonecrosis of the jaw.
As your experience in this area of bone-directed therapy, did you show many of the cases of osteonecrosis, and what is the proper management you advise? Because it is very difficult to treat such a complication.
Yeah. This is a very, very important point. The more conservative the treatment of the ONJ, the better. This is a very important information. You start with conservative therapy. You usually never start with surgery. Huh? You start with conservative therapy.
Any other question or discussion from the floor? So I would like to extend my thanks to Professor Thomas, and I would like to extend our thanks to Imogen, and Dr. Ibtisam will close the session.
Yeah, actually, I would like to thank Professor Thomas for his excellent, informative presentation that helped us to understand and update our knowledge concerning the role of denosumab in bone metastasis. And I would like Amgen for organizing this committee, and I would like to thank everybody and the audience for waiting just to this hour late, and thank you.